Well, hello, I'm Lane Young Walker. I'm a child and adolescent psychiatrist by training. I work at the Department of Mental Health as the Children's Services Director. And so I'm really excited about the opportunity to share some information about treatment of children and adolescents, medication treatment, but also we'll talk about some non-medication treatments as well, because I feel like those are really critical. When you're thinking about working with kids, it's not just about the pill that you can use, but the other interventions that you can use too. And so today it's about antidepressants and anti-anxiety medications. We will have 2 other webinars, and those webinars will be talking about other medications later. So today we'll cover the FDA status of the medications, and so what is approved, what is not. We'll also talk about informed consent. I'll go into some of those medications that we use that are titled or labeled as antidepressants and anti-anxiety medications. We'll talk about non-medication treatments that also need to be a part, ways that you can engage the prescriber. And I think that is very, very important because, you know, the front line is the Children's Division worker and or that foster parent. And so having some knowledge about the ways that you can engage with the prescribers I think is useful. And then the biggest piece of this will be our discussion, our questions that we have. So I want to make sure that everybody is very comfortable with using the chat function. If you have not tried to use it before, you might just use it as a test to make sure you know you can, because we will respond to those questions in the chat later. So one of the things that I want to make sure that we talk about, and you probably have heard this, I'm sure you've seen it in the news, is FDA and FDA approval. And so the Food and Drug Administration really makes decisions based on research and testing about what medications can be approved for what uses. And even though they make this decision and say that, you know, a medication is approved for treatment of depression, really no medication is entirely risk-free. There's a potential for side effects even with these FDA-approved medications. And so what has happened is that often the pharmaceutical companies will spend the time and the money to go through the research and the testing with adults and get an FDA approval in an adult population with a medication. And they've been less willing, a little reluctant at times, to do those tests with kids. So we have, and I'll go through and show you, we have much fewer FDA-approved medications in the child population than we have in the adult population. And so the topics that I wanted to talk about today were really antidepressants and anti-anxiety medications, but I want to make sure you're aware that there is some overlap. Although the label is antidepressant, antidepressants are used for depression and anxiety. And you'll see when I talk a little later that there's FDA approval of some of the antidepressants for anxiety disorders. So there's several classes or categories of antidepressants that we have identified and that we use. And really we base that class on, if you look, you know, biologically and chemically on the neurotransmitter that's affected, okay? So in our body and our brain, there's different neurotransmitters. We know through research that either having too much or too little of those neurotransmitters may contribute to mental illness. And so depression, anxiety, those kind of things can be the result of an imbalance in neurotransmitters. So SSRIs are a major class. They're really the number 1 class in treatment of depression and anxiety. And SSRI is a selective serotonin reuptake inhibitor. That's what that stands for. And so serotonin is the transmitter in the brain that is being affected by SSRIs. Then you have TCAs, which are tricyclic antidepressants. Those are older medications. They were used for depression a lot more in the past. But as we've had newer medications like the SSRIs and the SNRIs, then we are using the TCAs much less frequently, and I'll talk to you a little bit about why. Called tricyclic antidepressants because they affect 3 different neurotransmitters, okay? And then there's SNRIs, which are the selective norepinephrine reuptake inhibitors. So they selectively affect norepinephrine. And then the MAOIs, which are monoamine oxidase reuptake inhibitors. I am not in any way expecting you to remember these things. but you'll hear the doctors use these terms. So it's important to have some familiarity with what they mean when they use these terms. And so that's part of the reason why I'm talking about it and kind of spelling it out for you. And you know, everybody's at a different level. There may be some people in the room who have much more experience with pharmacology, and some of this may not be in any way new to them. So I'm not trying to put anybody out by making them think I don't think they know anything, okay? I just want to make sure, you know, I'm trying to give a baseline understanding for everybody. So when you look at FDA-approved medications in the antidepressant class, now remember I said antidepressants treat depression, they also treat anxiety. You'll see the first category is those that have approval in children for OCD, or obsessive compulsive disorder. And so there's a list of 4. I don't have to read them, but you will get this presentation, so you'll know. It actually shows the ages. So when a study's done to approve a medication through the FDA, there's a certain age bracket that they're doing the study with, a time period that they're doing it for, and a medication and a certain diagnosis. So we have approval for sertraline for OCD, but we don't have approval for sertraline for depression. So you'll see as we move to depression, there are only 2 medications that have FDA approval for use in children and adolescents for depression. And then there's one medication, which is duloxetine. It's a newer SNRI, and it is approved for non-OCD anxiety. So things like generalized anxiety is where it got the approval. And so when you look at FDA approval, it really only means there's been a study that shows effectiveness and safety in this age range for this diagnosis for this medication. That's really all that it says. So in psychiatry, you'll see that list is short, and I know that you all work with many more kids probably than I do, and you know that many of them are on medicines that aren't on that list. So it's really, really common for us as child psychiatrists or nurse practitioners or pediatricians, who are really the top prescribers for mental health medications for our kids because of this first line. It's common that we'll use what we call off-label medication. Off-label only means that the FDA has not approved it. It doesn't mean they're bad or there's something wrong with those medications. It just means that it hasn't gone through the rigor of the studies necessary to get the FDA approval. And so you'll find many of our medications fall into that category. So what I've given you here really is a list of SSRIs, NRIs, TCAs, MAOIs, like alphabet soup, and then the other category of antidepressants that we use. And you'll notice if you compare this list really to ones that are FDA approved, they're different. And so there's just a way that a provider can communicate when they go through informed consent, and I'll talk about that, but a way to communicate the fact that we are prescribing something that's off-label. And it's important that that does happen, although it may not happen on a regular basis. It's important that it should happen. So the names that I've given you under all of these medications are the generic names. So if you'll go and you'll look at the ones that are approved for use by the FDA that are in the SSRI category, escitalopram is a generic name. The trade name is Lexapro. Fluoxetine is a generic name. The trade name is Prozac. So you may hear different names which may confuse you. What I don't have in this presentation that we can try to get is maybe a list of generic versus trade names so you have a sense. It's the same medication. It's just branded in the trade name. And as a doctor, we can prescribe something and say we only want the trade versus the generic. And some of these medications have gone generic because they've been out long enough, and some of them have not. You'll find that most prescribers will check the box on the prescription that says, can substitute with generic if available. Because some insurances really push back, and they won't allow the trade name because it can be more expensive. So one thing that I'll make sure, and I've already taken a note, is just to get you a list so you don't get confused. You know, fluoxetine is Prozac. You probably know it as Prozac more than fluoxetine. Just a second. We are not moving forward. Because that was moved. Okay. So then we'll move to the anxiety medications, which are purely anxiety medications. You'll remember that I said there are some uses for anxiety for the antidepressants, but these are really just for anxiety. We have atypical anti-anxiety medication, which is buspirone. We have an antihistamine, which is hydroxyzine, and then we have the benzodiazepines, which are anxiety medications that can be used in children. The ones that have FDA approval, there's only hydroxyzine for anxiety in children related to the antihistamine. And then there is lorazepam for anxiety in children. The other is for seizures and spasms when you look at the other benzodiazepine. So there's very limited FDA-approved anxiety medications, just anxiety medications in children and adolescents. So I want to talk a little bit about informed consent and what that is. Really, that's the information that the caregiver, guardian needs to have, has to have communicated to them in order for them to give consent for treatment. And so, you know, there is often in doctors' offices and hospitals this form where you kind of sign consent to treat. It should have many of these elements, but I feel it's important for the provider to also communicate in a verbal way what informed consent is to you. So they need to talk about why we're going to treat in the first place, so what is the diagnosis, and what do we expect to happen from treatment. They need to talk a little bit about what's the risk of treatment versus the benefit, and are there any alternatives? So medication may be what the focus is on, but what are the other alternatives to treatment, including non-medication options? And then what's the benefit of just not treating? What could happen if we don't treat? That has to be discussed as well. The FDA status, if they're planning on using a medication, and then what are some of the potential side effects? Now, if you look at the handout or the printout that the pharmacist gives you when they give you a medicine, it could scare pretty much anybody because they have to list every single side effect or symptom that anyone in a study reported when they took that medication. That doesn't mean that it's a common side effect. What I want to focus on today when I go through the meds are really more common side effects and then the more serious side effects. So I may not list for you every single thing that's ever been reported, but I'm going to give you the information related to what we see most often and what we're most nervous about as a potential side effect. So I have some cases here, and that's just for the sake of kind of getting you thinking about what you might see. This first case is an 8-year-old who's got more and more sadness. The foster mom says since spring break that she's been pretty sad, and it's Memorial Day, so that's over 2 months. Was crying and, you know, coming home and going right to bed, eating dinner and going right back to bed, not wanting to be around anybody, and really not wanting to do social things at all. And so there's not a change in this child's life. As far as in the foster home, she's been in the same foster home for 1.5 years, and there's no known, you know, excess or outside stressors, but this change in mood has happened, and it's been longer lasting than a day or two. And so the diagnosis here really is major depression, and the focus of our talk is more medicine than diagnosis, but sometimes it's good to have a picture of what it looks like, what depression could look like, because you may question that a little bit when you are taking a child to a doctor. And I'm only giving you, I think, 2 or 3 cases, so I'm not showing you everything you could see. But this is a 16-year-old who just worries all the time, spends several hours worrying and has been doing it for months. Gets headaches and stomach aches and can't go to sleep because of the worries and just can't really function. Grades have dropped, used to be an A student but now a C student. So this is kind of a case of generalized anxiety where you have excessive worries on a regular basis lasting more than 6 months, and you also with that have a loss of functioning. The other thing that you saw in the other case was that loss of functioning. You know, a kid can have tics or sadness, but still function and not be extreme and maybe not need the medication. But in both of these cases, it's been more of an extreme case of symptoms that keep them from functioning well. So likely they would be treated. And then the third example is a 13-year-old who's late to school 3 days a week. His foster parents started having him put his clothes out at night, pack his backpack, get his lunch together, but he's still late. Why is he late? He's late because he takes a shower and then he touches something, he thinks he's dirty, so he takes a shower again. And he washes his hands and he picks up something and feels like he's dirty, so he washes it again. So he's spending lots of time in the morning getting up at 4 o'clock, but spending 2.5 hours getting ready because he's repeating washing and rewashing his body because of feeling like he's dirty. And he has this behavior at school too, so he's having a hard time getting to classes and things because of it. And in that case, you want to think about a kid who may have obsessive-compulsive disorder. The reason I chose these cases were, one is depression and two are kind of anxiety-type disorders. And you saw if someone's going strictly by FDA approval, we do have some medications approved for OCD. And we do have some medications approved for GAD, or generalized anxiety. And the history that we get in a case like that helps a prescriber determine what medication to use. So they'll look at, and I gave you a short history, not the whole thing that we'll get, but they look at the history of past response, family history of response to medicine, any type of interactions they've had before, compliance issues, medical issues, and cost too. I mean, some of these antidepressants are on the $4 list at Walmart. So if you've got a kid who doesn't have insurance or where insurance is a concern, then that may be the best choice. They also look at maybe the history of that child's symptoms and if they're refractory. It would be good if this didn't happen, but we do have some teenagers and younger who become pregnant. And so there are certain medications that are safer in pregnancy or safer if you're breastfeeding. And so those are things that are looked at, as well as side effects and their preference of the patient. Sometimes the patient may say, I don't want to take that because my mother took that and she has terrible side effects. And no matter what we say, they really don't want to even consider another option. So their preference is important. So when we think about all the medicine options, we look at FDA status, but we look at all of these things to kind of determine what is the next step or where do we go. And one of the things I'll talk about a little later is how important the patient perspective is. And for children and adolescents, that's the guardian. And that's also getting some sort of buy-in from the patient, especially if they're a teenager, and even if they're younger, because they have to take that pill every day. And we want them to have some buy-in and ownership of it. So one of the things overarching with all antidepressants to be really aware of is the black box warning, which you may have heard of. The black box warning relates to suicidality and antidepressant medications. It actually is there for other medications for other reasons. But for our purposes, there were some studies that happened. It started with Paxil, and it looked at increase in suicidal thinking and behavior in children and adolescents and young adults when they took those medications. That same pattern did not ring true for adults that were 65 and older. But what happened as a result of this concern is that every antidepressant got labeled with the black box warning. When that happened, there was a reduction in the use of antidepressants in teenagers, and there was an increase in the incidence of suicide attempts. And I think that made people have to stop and think, and not just be knee-jerk. Because when the black box first came out, I think there was knee-jerk reaction, and just we're not going to prescribe antidepressants. And that happened maybe more so in the primary care world than in the psychiatry world, but it did happen. And so in the end, I think the black box is useful. It's useful because it causes discussion to happen. It should cause discussion between the prescriber and the caregiver and the child that if you see a worsening of symptoms on this medication, you need to let us know. We cannot say that antidepressants cause suicidal behavior. We can't say that because we saw data that showed increase in suicide with reduction of use. But we can say that in some cases there is clinical worsening, and we need to be aware of that, and there needs to be communication about that, and then feedback to us if there's any kind of change that the caregiver, the child, the adolescent, anyone in their world sees, we need to communicate and not just jump and stop the medicine, but communicate and have a strategic way to address what's going on. Because we know that patients, no matter what age they are, if they have depression, they're at a higher risk of suicide. So the illness itself increases the risk. So now what I want to get into are those classes of medications that I talked about earlier. And I want to talk about the potential side effects that can exist with those different classes. Again, this is the most common. And then I will also highlight things that we need to be really, really cautious of because they can be serious. So with SSRIs, what I want you to get into your mind is you're going to see a repetition of many of these side effects, okay, across the different medications. Not all of them will be the same, but many will be. So upset stomach is somewhat common with SSRIs. One may cause it more than another. And that's not something you have to be aware of. That's something we have to be aware of. But just know that overall, upset stomach, maybe headache, insomnia, anxiety, sexual dysfunction are fairly common with SSRIs. One thing that can happen with SSRIs, especially with a person who's been on it long term at maybe moderate to higher dose, and then all of a sudden you stop that medication without slowly tapering off, you can get a withdrawal syndrome. And withdrawal syndrome, I'll identify all the components of that, but it is higher risk with some of the SSRIs than others. And it's important to be aware of kind of what that looks like. It's not necessarily life-threatening, but it can cause lots of discomfort for the patient. Serotonin syndrome can be life-threatening, and that's a potential side effect as well. So for the withdrawal syndrome, it's also called discontinuation syndrome. It can happen with any SSRI. It is more common with those that have a short half-life, so that those that leave the body quicker. And Paxil is the one that leaves the body the quickest. Some of the symptoms of discontinuation syndrome, if you look at them and compare later, are some of the same symptoms of side effects. So headache is there, just as it was before. There's also nausea, vomiting, and diarrhea, and we talked about stomach upset. Some of the things that are different with this discontinuation syndrome, though, are this numbness and electric shock type sensation. So feeling like there's shock-like things happening in your fingers and toes, and having sweating and shaking, which the tremor is shaking. Those things are different. So the importance, I think, for you all to be aware of is that if a child or adolescent is on an SSRI and has been on it for at least a month or more, there has to be a conversation about how you stop it and whether or not you need to taper it. And a lot of it depends on the dose and the amount of time that they've been on it, whether or not they're at risk of this discontinuation syndrome. So let's talk about serotonin syndrome. It is rare. It's not common, but it is serious. It can occur when you have high levels of serotonin that accumulate in your body. And the thing to be knowledgeable about is it's not just antidepressants. It's not just SSRIs that can cause serotonin syndrome. There are some medications for, I think, migraines can build up and cause serotonin syndrome. So it can occur when you increase the dose, typically, or you add a new drug. Some of our medications interact with each other. So it's fine to take, Prozac by itself, but when you take Prozac with maybe Strattera, then you may have a higher risk of a buildup because one inhibits the metabolism of another. And so when you add a new drug, you're at risk, potentially, of additional side effects and potentially serotonin syndrome. It can be life-threatening when it's severe, and some things to look out for are when it's at the severe end, high fever, seizures, irregular heartbeat, unconsciousness, and sometimes death. So I'm going to talk a little bit about what you see early on, but at the end of this, where it's life-threatening, you can see some of these real serious side effects. Early on, you might just see some agitation, or the child being more restless, confused. Their heart rate and blood pressure goes up and down, so you see that changing a lot. Their pupils will get large or dilate. They may have some twitching of their muscles or real rigid muscles, diarrhea and shivering and goosebumps. So with serotonin syndrome, you can feel very, very sick. And this is not a kid, I think, that is not going to rise to someone's attention, maybe not early on, but as it progresses, someone is going to see that this child is not physically well, and that usually brings them to medical attention. So I'm going to say a little more about it, just because I don't want you to forget it. Not because it's common, but it is very serious when it happens. There's that triad I already talked about of confusion, increased heart rate and high blood pressure, muscle rigidity or twitching. And in the medical world, we say mental status changes, autonomic hyperactivity, and neuromuscular abnormalities. They're the things we look at. There are some labs that we can do that show us that this is what's going on. But when we see these things, we should be thinking about it. And if we are not thinking about it, and you know about it, then you can say, could this be serotonin syndrome? It can happen really quick. It's not something that develops over days. Most individuals start to have symptoms onset within 6 hours after they've kind of started a medication or increased the medication, unless it's something that took a while to maybe build up. But it's usually not a slow process. So now I want to move to the NRI class. That's the second class. Some of the side effects are similar: nausea, constipation, headache, insomnia, sexual dysfunction. You can have the withdrawal syndrome too. And with venlafaxine, there's a chance at higher doses that the blood pressure can get high. And so the NRI is a selective norepinephrine reuptake inhibitor. So it's norepinephrine, which is why we don't have serotonin issues, but we can have other potential issues. Then I'll move to the tricyclic antidepressant class, which I said is not used as much anymore. It has a significant risk for interactions with other medications. That's part of the reason why it's not used. It can cause sleepiness and weight gain. I kind of put the reason why. It blocks histamine. You don't have to remember that, but that's the reason why you get sedation. The reason why you get tachycardia, which is increased heart rate, and orthostasis, which is when you stand up you get dizzy because your blood pressure drops, is because of alpha-1. And then you can get constipation, urinary retention, dry mouth, dry eyes, and confusion. So when I talked about tricyclic antidepressants, it affects 3 neurotransmitters: histamine, alpha-1 agonist, and acetylcholine. And because it affects 3, you can get side effects across those 3 areas. I've just given you a few. There are a lot more. The other things can be the elevated liver enzyme, the sexual dysfunction, withdrawal again. The problem with TCA is that if someone chooses to take this as an overdose attempt, the risk of death is high. Because there's a narrow window between efficacy and toxicity. And so being able to cross that line from being effective to being toxic is small. And there's a list of different tricyclic antidepressants that I talked about at the very beginning. And so some are worse than others, but still that risk is there. You will not find that it's used so much more now for depression because we have the SSRIs, we have the SNRIs, we have the other medications. But, and this is not in one of the webinars, but still it's used for enuresis, for kids who are wetting the bed. And the same kind of concerns happen, but it's used at a much lower dose for bedwetting than it would be for depression. The monoamine oxidase inhibitors, the MAOI, they're not used as much anymore either because of the same thing, limitations due to side effects, and there's interaction with diet for monoamine oxidase inhibitors. So there's certain things you can't eat, which I'll go over some of that. It is sometimes used when other antidepressants fail, and it works, but the chance of some of the side effects is limited to use. And when we as prescribers decide what we're going to use, we not only look at efficacy, but we look at potential side effects. There can be serious side effects when you combine it with certain foods. Foods that have things in them like tyramine, dopamine, or tryptophan. And I've given a list of a few things that contain those elements. There's a list that we can get and give them of all of the all of the foods that kind of interact. If someone is on an MAOI, there's a lot of education that should go with it from the pharmacy, and I would bet that most pharmacies should be giving you that food list to make sure that you don't take it. Take that food and take the medication. There's also some significant drug interactions, and not just medications that are prescribed, but over-the-counter meds, vitamins, dietary supplements, herbal remedies that can interact with monoamine oxidase inhibitors. So when they interact, they can elevate the levels of tyramine to where we have what's called a tyramine crisis. And you can get lots of different issues with blood pressure and vital signs. Most commonly, though, if you don't have that interaction, you're not eating those foods, you don't have the medications on board that can interact with it, you still can get some of those similar symptoms of dry mouth and nausea, dizziness, constipation, drowsiness, headache, and insomnia. So I think it's important, it will be rare that you'll have a child on MAOI. If someone's on an MAOI, it's often an adult. But if you have a child or adolescent on a monoamine oxidase inhibitor, you really, really need to be aware of, and they need to be aware of, dietary restrictions and other medications. So I think bupropion is next, and bupropion is Wellbutrin. Typical side effects are dry mouth, constipation, headache, dizziness. So these are a common pattern. You'll see a lot of these over and over again. Nausea, vomiting, heavy sweating. The difference between bupropion is this last one. If you have an eating disorder like anorexia, or you have a seizure disorder, bupropion can lower your seizure threshold and cause you to have more seizures. So if there's anything you remember about bupropion, it's that final bullet about the seizure threshold. And then mirtazapine can cause drowsiness, and sometimes we use it to help with sleep and mood. Dizziness, it can affect dreams, cause some changes in vision, blurry vision, increase the appetite. We can see maybe weight gain with mirtazapine. And trazodone. Now, trazodone is an antidepressant, but often you probably have seen it used for kids who can't sleep. So to use it for depression, you have to use it at higher doses, like 300 milligrams. But when you use it at the lower doses, like 25 or 50, which is probably what people commonly see, then you get the side effect of it, which is drowsiness or sleepiness. And so some people are preferentially using it just for insomnia at those lower doses. You won't really impact depression unless you get to those higher doses. But other side effects from it can be that blurry vision or that dizziness when you stand up too quick. So if you're laying down sleeping and all of a sudden you pop up and you're standing up and you get dizzy and you may fall. Those are some of the more common ones, but there is a rare and serious side effect. Now, this is one that I always get laughs from the teenage boys when I say it, but I mean, it can be very serious. It's priapism, and priapism is when there is an erection that you have that doesn't go away. So it's sustained for hours, it's painful, it won't go away, and you need medical intervention to treat it. And even though my teenage boys laugh, I try to help them understand this is very rare, but it's serious. There have been people who have needed grafts and medical intervention to make this go away. So, you know, you'll find that even though some people will really use trazodone for sleep, and they'll use some other of our psychotropics like the antipsychotics for sleep, I think you have to be cautious because there is a potential of some serious side effects. And so it's not on label. Trazodone is not on label for sleep. And if you are using it just for that, you have to make sure you're telling people about this rare but serious side effect, you're monitoring for it, and honestly that you're making sure that they really can't sleep. You know, what I found in my clinical practice is Kids will say, adults will say, I don't sleep at all. You know, it takes me till 2 o'clock in the morning to fall asleep, and then I'm up all night. And clinically, I do some work with Division of Youth Services. So I see kids who are in custody. So we can know whether they're sleeping or not because there's staff there that are watching them all through the night. And one of the things that we have done is to make it standard that if you say you're not sleeping, that we check your sleep logs and see if you're not sleeping for at least a couple of weeks. And it's amazing how many times I get from the patient, I'm not sleeping at all, but a sleep log says they're asleep by 10 o'clock every night and never wake up. So, not to be on a soapbox, but the moral of my story on that is when a kid is saying they can't sleep, there are other things that can be done before a pill to help with sleep. There are things like sleep hygiene, making sure, number one, they're not drinking too much soda or caffeinated beverages, that they're not using their bed for all activities all day long. They're only using it for sleep, that they have a set time that they lay down in bed to go to sleep, and if they're not asleep within 30 minutes, 40 minutes, they get up and come back. And those things related to sleep hygiene will help. Also, if they're active during the day, they're going to be more likely to want to wind down at night. But if they're napping during the day, they're not going to be able to sleep at night. So I would encourage you, and this is one of my pet peeves, that if you have a child in your custody that's saying they can't sleep, that other things besides a pill are looked at first. And then you come to maybe a medication. And this is not a sleep talk, it's a depression talk, but there are herbal remedies like melatonin and some other things that can be used before you go to a prescription for sleep medication. Buspirone, as I said it early on, was just for anxiety, so now we're kind of crossing from depression and anxiety medications potentially to only anxiety medications. And so buspirone can cause dizziness, nausea, headache, nervousness, lightheadedness, constipation, blurry vision, sleep problems like strange dreams or inability to sleep. If you remember, is not FDA approved, but we do sometimes use it for anxiety. Hydroxyzine, which has multiple uses. I mean, it's used for itching. You might know it as Atarax. You might know it as Vistaril. It is used sometimes to help with anxiety. It has an FDA approval, actually, in kids for anxiety. It can cause fatigue and nausea, dizziness, dry out your nose and mouth and throat. It's a very rare thing, but it can cause some heart abnormalities. So prolonging the length of time between beats, so prolonging the QT interval on the EKG is a possibility. And then we get to the benzos, and I bold them because I want to make sure everybody's hearing me loud and clear. Benzodiazepines are FDA approved to treat anxiety in adults. They are not FDA approved to treat, other than the one, lorazepam, anxiety as a rule in children and adolescents. They are sometimes used, especially with kids who have seizures. Clonazepam is used often with seizures. But they are rarely used in our population just for maybe anxiety because of the addiction potential. So if you use a benzodiazepine, some are more potent than others. Some are going to require you to escalate the dose more and more than others. But they all do that, and they all, you build up tolerance, and you may need more of it to get the same effect, and it may be very hard to get you off of a benzodiazepine. So that's one of the reasons why, we as child psychiatrists for sure will usually try to start with an SSRI for anxiety versus a benzodiazepine, and as a last-ditch effort, or if there's severe functional impairment and we have no other options, we may go to a benzodiazepine. The other thing to be aware of, though, with it is that, you want it to calm, but it can have a paradoxical effect. So instead of calming a child, it may make them more agitated, more angry, more aggressive. And so that paradoxical effect is something to be aware of. And then that withdrawal that I talked about can lead to seizures. So if anyone has been on a benzodiazepine for, a long time at a high enough dose, and you stop it, and you don't taper it, you can have withdrawal seizures. But common side effects, just for you to be aware of, is, a loss of memory for events around the time that you're taking the medication. It can impair thinking or cognition. So that's another reason why it's a challenge for a kid that's in school that's taking a benzodiazepine. It can increase depression or sadness, drowsiness, coordination, like stumbling around, not being able to be steady on your feet, and dizziness. So I've talked about FDA approval and what's FDA approved and not. I've talked about informed consent, which is a critical part, and side effects. But there are some medications that require either blood monitoring or other medical monitoring. And so I've tried to list the different categories and whether or not a monitoring is needed. And really for SSRIs, you don't need to unless you think there's serotonin syndrome. And then there's a cascade of labs that we do, and typically that person's in the hospital if we're working up serotonin syndrome. For the SNRI, there are two that you need to think about labs, and I've talked about it a little earlier. The venlafaxine, SR, blood pressure can escalate at higher doses. So like a dose of 225 or higher, you have a higher risk of high blood pressure, and so you need to be checking it as you go up in the dose. And then duloxetine can increase a liver enzyme that's called ALT in a small number of patients, like 1%. But there is a recommendation that after you start the medication, you do check the ALT at least once. And if you're concerned about liver issues, you see like clinical symptoms like jaundice, which is yellow color to the eye. You see things. You might feel the liver being enlarged on physical exam. You might want to check it more than just that time after starting the medication. And during the informed consent phase, be able to talk to the caregiver and the child that if you notice these things, you need to let someone know. The TCAs, or the tricyclic antidepressants, if there is a pre-existing heart disease, then before you start it, and when you get to a therapeutic level, you need to think about checking the TCA EKG, the EKG for the TCA, okay? So only if there's a pre-existing heart disease do you need to get that EKG at the start and when you get to a therapeutic dose. But there's really only one tricyclic antidepressant, that's nortriptyline, where it's recommended that you get the level, you draw blood and get a nortriptyline level, because the range, and this is a typo, is between 50 to 150 to be therapeutic. And so for the others, you can check levels. There are levels, but this is the one where the literature and the research says you really need to check levels. The MAOIs, there's one of them, phenolzine, which can cause liver failure. So they do recommend that you monitor liver function after you start it. And so you would check the LFTs, and if you're noticing any clinical symptoms, if the doctor sees that, then they would check those again later. And then many of them don't require any monitoring. So bupropion, mirtazapine, trazodone, buspirone, hydroxyzine, and I didn't put this on the benzodiazepines, but there's no real monitoring. The only time with hydroxyzine that you would check any kind of medical monitoring or lab would be if there's an overdose situation. And if you go back and remember what I talked about, the potential of prolonging the QT interval, so affecting the heart, you'd want to check an EKG for sure if you think there's been an overdose situation with the hydroxyzine. But on a day-to-day, as a case manager with a patient that you're taking care of, unless you think they've overdosed, there's no real monitoring. So non-medication treatments, and I'm not saying that I'm telling you everything that exists because I'm not, but I'm just going over a few things that are evidence-based that have been proven to help with anxiety and depression or one or the other. And so both depression and anxiety respond to cognitive behavioral therapy, or CBT. We have some specified trauma-focused therapies for kids who've had trauma, abuse, and so there's trauma-focused CBT. There has been for years, and maybe there's some controversy in some camps about EMDR, but eye movement desensitization reprocessing has been used with trauma. And then a newer to this area, but not necessarily just new, is child-parent psychotherapy. And that is for children under 5 who've experienced trauma, and they enter into like a dyadic therapy with their caregiver. And that can be the foster parent if it is not, if there's been termination of rights, or, you know, if the parent is still involved, that relationship can be with the foster parent and the biological parent and the child to try to work on the trauma. So that is not everything in the world, but those are some ideas of some non-medication therapy options. And then there's some just lifestyle changes and things that you can do to try to help with depression, with anxiety. Again, it's not an exhaustive list, but, you know, exercise and increased activity definitely are things that can be used. Social interactions, you know, if Kitty's really depressed, may start to withdraw and not engage so much socially. Stable and consistent sleeping and appetite patterns, those things are all helpful as far as some non-medication options. And I know there's other things too, so when we get into the question piece and the discussion piece, if there's things that people have questions about or know that they've seen work, I'm happy to have you fill those out too. So I'm going to switch gears, and I want to talk about how you engage with your provider, not always a physician, but how you engage with them in the process of treatment. So if you look historically, the relationship between the doctor and the patient was really paternalistic. The doctor told you what to do, and you said, okay, and you did it. And that was it. And you didn't really ask any questions, and you just moved forward. But really, we've changed in the way that we engage with patients, and the way we teach medical students how to engage with patients. In my experience, I've done some work with medical students and residents and fellows, and now it's not about you have the knowledge, you tell them what to do, and they do it. It's about how are you going to work with that patient? How are you going to work together to make sure that they understand what's going on and have a role to play in their treatment? And so we as providers expect, and I want you to hear this loud and clear so you don't feel afraid to ask questions. We expect questions. We expect there's going to be dialogue and discussion. We expect that your input into the process of evaluation and decision-making is important. And so I don't want anybody to feel like you have a doctor that you can't engage with, because if you do, you probably need to switch doctors. Because the reality of today's world is the expectation is that there will be more engagement in that process. And it may not just be a doctor. As I said earlier, you could have a nurse practitioner, a physician assistant, a resident in training who's reporting to their supervising attendant. So the playing field of who you engage with may not always be a doctor. Okay. Okay. And so when you engage with that provider, it's really important and very helpful for us to have information. And that's hard because a kid gets kind of pulled out of their home, put in a foster home, and nobody has data. Nobody knows necessarily all the details of their past history. And it's understandable, and that may not be available right away. But whatever you have, it would be really good to be able to share that. So any documentation about past hospitalizations, outpatient treatments, medications, medical history, all of that is really important. I think what sometimes happens with some foster kids is they get moved around a lot. They act out, they move from one place to another, and that history is not passed on. And so they go from one doctor to another, and instead of thinking through a process as the doctor and or provider, we just add another medicine. Or we just, make a decision based on that moment in time and not looking at the history of the patient. And so anything that you can help us with giving us information on will help that child. And so I said it before, I'm going to say it again. I think they say if you say things 3 times, people remember them. This is my second time. I'll make sure I do it a third. Be empowered to ask questions. A key component of that informed consent that I talked about earlier is that you need, as the caregiver, guardian, whether it's the worker, the foster parent, whoever, to have the information that you need to understand what's going on about the illness, potential treatment, and to give a consent to treat. If the provider has not given you that information, they haven't done their job that they need to do. And if they haven't, then you need to ask questions till you can get what you need. And so if you don't understand, too, because we get taught in jargon, SSRI, SNRI, and all these other terms because that's what we're used to. If you don't understand what they're saying, you can say, hey, wait a minute, slow down. Can you explain that to me? I don't really know what you're saying. To have them try to break it down into a more understandable format and not medical jargon. The other piece of your engagement is that ongoing feedback. Yes, we need information at the beginning. Yes, we want to make sure that you're engaged in the process of decision making. But when you walk out the door, you and or the foster parent or whoever it is that spends the most time with that child is the best person to let us know what's going on from your perspective. We also want to know from the child's perspective. And the black box warning says families, caregivers should be advised of the need to closely observe and communicate with the prescriber. So it spells it out in that context. But I think that observation, communication is critical, not just in the context of SSRI, but in the context of all the treatments for that child. And so caseworker may have some feedback, foster parent, teacher, whoever can give us that data. They don't have to be at the appointment, but somebody needs to bring that data to the appointment so that we can make educated decisions about next steps. And then there may be things you need. And this webinar, I hope, will be a step to helping you give you some of the things you need. The handouts that I'm going to try to make sure that I can get to you all will help you get the information you need. But you have to educate yourself to some degree on the treatment because you may be the one making the decision, yes or no. So you have to understand those elements of informed consent. Be familiar with the side effects. You don't have to memorize them. I need to know them by heart. You don't need to know them by heart. But you need to know where to find them, either the pharmacy or pulling up this presentation or talking to other people. Be knowledgeable where you can find that information. And if that child is experiencing potential side effects, to be able to communicate that to somebody. And that there are some medications that there'll be labs that are needed or blood pressure, some sort of monitoring. There are others that won't. Hopefully this list will kind of help you. But there are places you can ask those questions of. If you don't know and you go to a doctor and you're thinking, well, I wonder if they need to have their blood checked, ask that question of that provider instead of wondering. So I did want to take a pause here to see if there were any questions related to just engaging with your provider, because I feel like that's a real critical piece. And actually, my presentation will be completely done, so we can ask questions about other things, too. It doesn't have to be that. But I think that's one of the things that may be a challenge for people. There may be other things, too. So we're going to open up the chat. My last two slides really are some resources for you, and I'll go through those after we go through questions really quick, and that's it, after the resources. So we're going to go up to our first question, and I'll try to respond to everyone that we have. We added extra time on this webinar just to make sure that we had time for questions. So the first question is, what are the potential issues with using non-medication treatment? So one of the things that I think is critical to know is that sometimes the non-medication treatment needs to be the treatment. Sometimes it's not the medication first. Okay, some examples. If you have a really young child, maybe a 2, 3, 4, 5-year-old, often a therapeutic intervention is the only intervention that you start with. And the decision about that has to come from the provider, who hopefully has the knowledge and experience to know when the impairment is severe enough where you need to put a medication in. So, I talked about tics earlier. So tics are involuntary muscle movement, like a blink of the eye or a switch of the neck, right? And some kids may have tics that don't impair their functioning at all. They can get through the day. They're not having kids tease them about it. It's there, but it's a nuisance. There's no need to put a medication on board for that. There may be other things you can do to help reduce stress level, right? But that same kid may be ticking all the time, so much so that they can't even focus in class. They can't get through their day. That's a difference. And that kid might need medication versus a non-medication intervention. So as a provider, we're looking at severity of illness, we're looking at impairment of functioning, and we're looking at age as well. I'm less likely to give a medication to a really young child, if I don't have to, than to a child who's older, just because often in the young child's experience there may be other things, environment, parenting, different other things that you can shape and change that young child's behavior. So it's not a cut and dry answer. I wish I had one for you. It's an answer that has to do with multiple facets and has to be discussed. Because if you really feel like, well, hey, it's an issue, it's there, but this kid is still functioning well, you can say that to the provider. We want to look at things we can do to treat, but we don't want to do medication yet. And they should be able to dialogue with you if they are totally against that because they see and have experience that it's more serious than you think. That dialogue should happen. And the next question is, when should antidepressant therapy cease? What do you need to see to make a recommendation to discontinue it? So in the summary of some of the studies, I gave you studies on kids, right? So one is the TADS, which is treatment of adolescent depression, and one is the TORDIA, which is treatment of resistant depression. And I gave you the names of those and kind of what they look at. The studies that we have that look at length of antidepressant treatment, and we do have them, they're adult studies. So we have what we always do, which is not a one-size-fits-all, but we've extrapolated from adult studies, and we are using that same theory and philosophy with children and adolescents. The adult studies say that if you've had single depression, one depressive episode, you treat it adequately and successfully, which may take 9 months to a year, and then you do a trial off of medication when they're asymptomatic. So you've gone for 9 months on this medication, stable, not having the depressive symptoms that you had before. Maybe you've also had some therapy, so you've learned coping skills. After 9 months in that first episode of healthy non-depression, you try off of it. There's a 50% chance that there'll be another depressive episode in life. And again, this is adult data. So a 50% chance that maybe you'll have to treat later. But 50% of those people never have to be treated again. So it's worth trying off. Second depressive episode. You want to definitely treat for that same amount of time, probably closer to the year. It doesn't give you lifelong treatment, right? You're going to do another trial potentially off. But that trial off is going to probably have less success. There may be another episode of depression, which is at a higher rate than 50%. But you treat for about a year. Asymptomatic, you do a trial off again. And if there's a third episode of depression in the adult data, it says treat for life with medicine. So we don't have a study with kids that gives that same kind of feedback. My stance as a clinician is I don't believe that you as a child or adolescent should be on a medication for your life unless we've really tried numerous times to have you off and it was unsuccessful. And we've tried other things besides medication, other interventions, in addition to medication. So that's all we have at this point. And I still will take any more questions. I'm surprised that we don't have more. This is your opportunity to ask anything you want to ask. If I can't answer it, I'll let you know that. One of the things that came across that I talked about in my talk was about sleep and the use of trazodone and other psychotropics. And I am a opponent. In other words, I do not believe that you should be using Seroquel for sleep, Risperdal for sleep, antipsychotics for sleep. You'll hear in the next talk I do more about antipsychotics, but they can cause metabolic syndrome. Sorry, just a minute. Metabolic syndrome can cause high cholesterol and risk of diabetes and high lipids like high cholesterol and other lipids like LDLs and triglycerides. So you can have an increased risk of diabetes and an increased risk of heart disease from using Seroquel and Risperdal and all of those medicines. I'm not saying don't use them. I'm saying I am not a proponent of using them for sleep. If sleep is the problem, to me, if you look at risk versus benefit, you can't sleep, you're diabetic. I think can't sleep is probably a better place to be than to be diabetic at age 9. So I know a lot of people use antipsychotics for sleep. I know that there's more in the literature about trying to look at other things, and I do think it's problematic. At Children's Division, we see those drugs being used for sleep. It is not uncommon. Seroquel is an antipsychotic, right? And I spoke to this because it is not uncommon, because people are doing it very regularly. There is no FDA approval for Seroquel or Risperdal or Abilify or Geodon for sleep. There's been no research to say that it's effective and safe. And yes, we use things off-label all the time. My clinical opinion is I don't want to risk diabetes and cardiac disease in a kid that's not sleeping. I would rather use something else. Now, I'll tell you, some of the kids that we see are pushing for it, especially, when they've had it before and they're using it. Sometimes they're subverting it, they're giving it away, they're selling it, they get a buzz off of it. And so I think my opinion is if we could kind of totally get away from Seroquel for sleep, we would do it. But many people are doing it, and I question it. During the summer, is it okay to allow the children to not be on their meds that they're prescribed and allow teachers to handle and allow the teachers to be able to handle them better? So what you may be talking about is the summers free from ADHD treatment. There are people that will give breaks from stimulant treatment in summers and maybe even on weekends if the parents can manage and handle the inattention, hyperactivity, and impulsivity. They do that sometimes because when they're on the stimulants, they don't eat as much. They can't sleep as well. So they're trying to manage side effects. So they're giving this kid a break from the stimulant. Just know that with ADHD, if it is ADHD and the break over the summer for that, when they're not on medication with ADHD, their symptoms are not in control. And so an ADHD child who's on a stimulant and they're 16, and you say, I'm going to give you a break over the summer, but they're driving, you're increasing their risk of possibly an accident because of inattention while they're driving. So it's not just school, depending on the age of the child, that is impacted by the symptoms that might still exist without the medication. You should not take breaks from antidepressants because they take, and this is something I didn't talk about, but they take several weeks to build up in the body before they're effective. It takes up to 6 to 8 weeks of taking sertraline, which is Zoloft, or fluoxetine, which is Prozac, before it's built up enough in the system to be effective. So if you then take a break on the weekend or take the summer off, then you're not having efficacy for treatment of depression. And those medications are usually taken year-round all the time until the decision is made to take them off. The same with anti-anxiety medication. The same with a child who might be psychotic or hearing voices. Those typically don't have breaks. The only thing I've really seen people do is breaks for stimulants in the summer. Even the non-stimulants that treat ADHD, which I'll talk about later, they build up too. So taking a break from them is not the same as a stimulant where you take it and it acts and it's gone by the end of the day. That's the only medication that is effective for several hours and then not effective, and effective immediately and then not effective. If there's another question on that, let me know, because I'm only seeing it from a stimulant perspective, but if you have knowledge of something else, let me know. Is it possible to submit questions once the PowerPoint document is available?
So we have a part 2 in this series. It could be possible that we have a follow-up time question in your second webinar.
So yes, what can definitely do, it was June 6th, We're doing mood stabilizers and antipsychotics. July 6th. I did my best to remember, and I guess I didn't. July 6th, antipsychotics and mood stabilizers. We have, I think, 2 hours open for these calls, so we'll make sure that if there are questions that come after you get the PowerPoint, that I answer those questions then as well. And I'll try to make sure, if it can be sent to you ahead of time, that before July 6th, I'm going to work on it. I'm not promising. I'm going to try to give you that PowerPoint before the presentation. So there are some questions that are higher up, if you can go up. What substitutes can be used for sleep concerns? I have seen the use of melatonin. Is that okay? So the first thing I do is and I learned this the hard way. I had a teenage boy who came to see me, and he was talking about how he didn't sleep. He was up all night, and I was about to write a prescription for something. And then I noticed he had like one of those big tumblers. And I said to him, "What's in that cup?" And he said, it's green. The one with a lot of caffeine, the soda with a lot of caffeine. No, it was a soda with a lot of caffeine in it. And so when Mountain Dew. So he says it's Mountain Dew. I said, "Really? How many of those do you drink a day?" He said some ungodly number. I think it was like 5 or 6. And so then I had to sit back and say, that's probably why you're not sleeping. And that could be why you're pretty anxious. So it was a miss for me. I totally missed asking that question in my screening. Had it not been for me noticing that cup, I wouldn't have asked it. So I think when there's a sleep issue, the first thing is asking questions about sleep hygiene. Caffeine intake, sleep habits, sleep during the day, making sure that sleep hygiene is appropriate. And then once that's the case, if you know that's the case, and you know they're truly not sleeping, then I typically will often go to an herbal medication like melatonin first. I know there's some people that don't really like it as much, but that usually is my go-to first. Unless, if they have lots of anxiety and they can't sleep, then I might use Rimron because it treats anxiety and it has a side effect of sleeping. So if I can pair one pill for 2 uses, then I try to do that. But if there's sleep and then there's something that really I can't treat the sleep with what else I'm treating, I will go to melatonin first. There are some studies out, too, if you wanted to kind of Google search that about the use of melatonin with ADHD in particular. The next question, what are common signs of overdose from antidepressant? So that's variable. When I talked about antidepressants, I talked about tricyclic antidepressants, and that overdose is usually fatal. Usually people who take tricyclic antidepressants, they have cardiac issues, their heart stops, and then they die. And so you have to look at kind of the different antidepressants to see what overdose symptoms would be. And what we can do is I can try to get that. Can we get that to people with the PowerPoint? Mm-hmm. Okay, and try to give you just a list of the potentials, not so much of an issue with SSRIs. Of course, when I talked about the increase in blood pressure from venlafaxine, if you overdose on that, you can rise your blood pressure up.
And to be clear, a list of potential overdose
symptoms from overdose of the different antidepressant classes. What about when a child has a change, like an increase in the sertraline medication for a child? Does this also take 6 weeks? Yes. So we will usually start a child at a starter dose to make sure they don't have side effects. If it's sertraline and they're a teenager, it may be 25 milligrams. And often we'll do 25 milligrams for a period in time. It may be as little as a week, as much as 2 weeks. And then we go up to 50. That 6 to 8 week time starts clocking again when you go up in dose. So it's not from when you start. Yes, it's 6 to 8 weeks to see how effective 25 milligrams is. But if you want to see how effective 50 milligrams is, it's 6 to 8 weeks after you start the 50. Can sleep hygiene details be sent out? Put that down here. Okay, so there is an actual, in the clinic, I train fellows, and so they have an actual sleep hygiene sheet that they give to the family. that talks about the things they should do. Don't sleep during the day, limit your caffeine intake, sleep in the same place every night if you can, at the same time. And so there are details about good sleep hygiene, and I have access to those, and so I'll make sure that you get those too. You may get the PowerPoint before you get all these other ancillary details, but we will make sure that you get everything. I think that we may be winding down. That's probably all of our questions. If there are questions that you have, do they just keep them and then put them in the next chat, or do they send them to you?
I think we could do both. I think if you wanted to ask questions after you get the PowerPoint, you're welcome, and maybe it might be best to send them to Lori Masick. I don't recall now, I say that, and I don't know Lori's email off the top of my head. Lori, if you're on, would you mind sending your email address? And so folks can send their questions to Lori, and you can also hold them and wait. We'll make sure to schedule time on the second webinar for you to ask follow-up questions to the first as well.
And so a question came about, is there a certain dosage? I think that, is there a dosage to the melatonin? I'm assuming that's what that question's about. If it's not, please chat and let me know. Often the start is 3 milligrams, going up to sometimes 9 milligrams. If they're a teenager, if they're young, then we may stay at the 6. But I usually feel comfortable 3 to 9 milligrams as my personal opinion. I've seen other prescribers go up to 10. I don't tend to go much more than 9. If 9 is not working, then I'll try something else. There's a question, could we receive a portion? There was a thank you, and it says, could we receive a portion? Oh, yes, you can get this one right away. What is the best way to handle a psychiatrist? Go up just a little bit. There it is. What's the best way to handle a psychiatrist? Or tips to utilize when working with a psychiatrist that states we are playing doctor and we are not receptive to, and they are not receptive to our questions or insights. You know, honestly, okay, I am a psychiatrist, I am a physician. I know some physicians have a chip on their shoulder, or they believe that they know everything, and I don't think anybody knows everything. That's just my opinion. I also believe that if you're respectfully asking questions as the guardian, there is nothing wrong with that. And if your doctor is not willing to communicate with you, and I know sometimes it's hard to find a psychiatrist, I know sometimes you're limited, so you just stick with what you have, but that's not a good doctor who's not willing to work with you and wants to tell you that you're playing doctor. It's a different thing for you to say, use this medicine instead of this medicine. I'm not telling you to do that. I'm telling you to ask questions, to be inquisitive, and if you have concerns, to express those. And if you feel like the person you're expressing concerns to is not listening to you, that may not be the person you should continue going to. The dose of antidepressants is variable depending on the age of the child. So I can't just say this is the dose, because if I'm treating a 6-year-old, I'm using a lower dose to start with than if I'm treating a 15-year-old. If I'm treating a 15-year-old who's had multiple side effects from other medications and seems to be sensitive to treatment, then I may give them a lower dose to start with. So there's not a one-size-fits-all, it's this dose. It's really clinician's decision based on that history that you get. But it's important to look at everybody as individual. And in general, we do, you know, a teenager will get this dose, but if it's a teenager with medical issues or whatever, we may back down on the dose. Is there a recommended age to start melatonin? So I think melatonin does not have FDA status approval. So anything we do with melatonin is off label. And that's where it's important to document, you know, use melatonin, explain that it was a non-FDA approved medication. And so there is not a recommendation start. I think in the studies I've seen, it's always been about 3 milligrams, which is why that's where I start, because I feel more comfortable with going where the studies I've seen show. And there is not a recommended age either because it's not FDA approved. And with herbals and non-prescription medications, you're not going to have that necessarily because they're not FDA approved. They don't have those ages on them. For really young kids who are not sleeping, I mean, I've seen things like even Halcyon and other stuff that I don't agree with. And I really think we got to figure out, why are they not sleeping? Have they been abused and traumatized and they're afraid to go to sleep? What can we do to help the reason they're not sleeping, and then maybe they'll sleep better? So it's not always just about the symptom you see, but the reason behind the symptom. And if you can fix that, then you can help and improve it. And so the question is, impact in the liver for melatonin. There is a possibility, just like the other medication I told you, with a 1% chance. It's not huge, and we don't see it often. Then one thing, question I have is, do you talk a little bit about psychotropic med monitoring? I think that is, med monitoring. If that's not what that is, the person who sent that question maybe tell me. But psychotropic med monitoring is through Medicaid for years. There have been these edits where if a child is getting a certain medication and is at a certain age, they may hit the edit where a clinician needs to look at the case just to kind of make sure it makes sense. And so really most of the edits go seamlessly through so that if there's additional paperwork or whatever, it happens and then it moves through. But then there are some edits for really young kids, like under 5, where a clinician takes a look at it. And that's just a way really to help make sure there's quality. You'd be surprised at how many clinicians have not regularly checked fasting lipids and blood sugar on kids who are on antipsychotics when the American Diabetes Association makes that recommendation. And so if they're not doing it and you don't know they should do it, and it's not getting done, the risk to the child is there, and HealthNet or Medicaid has stepped in and said, we want quality treatment for our kids. It's not that we're not going to approve it, but we want to make sure you're doing the basic things that are required for use with this medication. And they've really looked at really young kids, under 5 at first, to really try to set that stage for quality care, and then, moving that up to under 9. So, I think there are some ways that HealthNet or Medicaid is trying to improve the quality of care that our kids are getting. And I think that it does make people frustrated at times, but I think in the end it only will enhance the treatment that our kids are having. Okay, so this is something people should hear. I once had a foster parent hang a dream catcher above the child's bed to help him sleep. And it worked for a bit, but then it stopped working. So they took it outside and emptied it out, in quotes, and hung it back up, and it worked again like a charm. So this is a kid who's not sleeping because they're probably having nightmares, they're afraid, they're anxious, but just having this visual of all the bad dreams are stuck here, and they're not going to bother you. The things that are bad are not going to bother you. Cause that kid to be able to sleep. He didn't have to have melatonin. He didn't have to have Seroquel, thank God. But think about if someone hadn't tried to go back and think about, why are you not sleeping? What can I do that isn't maybe a pill that can help you sleep? That will work. Sleep hygiene will work. Try those things first. If they don't work, then you have other non-prescription options and prescription options. So I think that's it, and I want to thank everybody for their participation. Lots of questions. Be thinking about more questions for this once you get the PowerPoint and for the next presentation, so we can have really a back and forth discussion about mood stabilizers and antipsychotics. So thank you very much.